Imagine for a second that you're a busy family physician. You've got a patient sitting right in front of you who is undeniably, seriously sick, but their test results, they're pointing in a dozen different directions at once. You want to dig deep into the medical literature, you really do, but you have a waiting room completely full of people. Well, in today's Explainer, we're going to dive into exactly how one service, Anvera Consilium, steps in to solve this exact bottleneck. We are going to follow a ticking clock on a high-stakes clinical case, taking it from a total blank stare to a deeply researched, actionable medical memo in just 46 hours. Let's get right into it.
So we start with a really puzzling medical mystery. We're looking at a 52-year-old man in Bengaluru with severe but frustratingly vague symptoms that left his family physician totally undecided. This isn't your classic textbook case where the diagnosis just jumps out at you. Not at all. This is exactly the kind of real-world scenario that keeps doctors awake at night. The physician knew in his gut that something was very, very wrong, but he simply couldn't decide which differential diagnosis to pursue first without spending hours, literally hours, buried in clinical journals.
The dilemma here is so incredibly clear when you look at the numbers. We are seeing classic B symptoms: 3 months of crushing fatigue, 6 kilos of unexplained weight loss, and these low-grade evening fevers. That is alarming. Then you check the inflammation markers, right? An ESR of 78 and a CRP of 42. Those are markedly, screamingly elevated. But here's the kicker. The entire first-line workup, completely normal. The chest x-ray is clear, the abdominal ultrasound is totally unremarkable, and the patient is HIV non-reactive. So you have these blazing inflammatory markers, but absolutely no obvious fire. To figure this out, the doctor turns to Consilium's Chamber Junior model, which is, honestly, an absolutely fascinating approach to medical research. Think about the legal profession for a minute. A highly experienced senior counsel doesn't spend days locked in the library reading every single precedent, do they? No, they have a sharp junior counsel, a chamber junior, who does all the heavy reading, appraises the evidence, and then brings the senior lawyer a meticulously prepared brief. Consilium takes this exact same logic and applies it directly to medicine. Now, in this dynamic, the crucial point to understand is that Consilium acts as the meticulous researcher, while the treating physician always remains in charge. The Consilium Clinical Research Associate, or CRA, is a qualified doctor themselves, and they're doing the deep appraisal, but they are not the doctor for this specific patient. The treating physician remains the physician of record at all times. They're the ones issuing the directives, making the final call, and signing off on the treatment. Consilium is strictly an advisory service. They're just there to make sure the doctor has the absolute best possible evidence sitting right in front of them. What's really cool is when we track this exact case, we see it unfold over a rigorous 46-hour window. We aren't looking at some vague, theoretical, we'll get back to you when we can process. We're looking at a tightly orchestrated operational workflow. From the very second the doctor clicks submit, to the automated data sweeps, the human analysis, and the final delivery, every single minute is accounted for. The clock officially starts ticking at 10:42 a.m. on a Tuesday. That's when the case lands in the Clinical Research Associate's queue. The CRA opens the file, and they don't just skim the doctor's question. They meticulously read through the entire patient profile. They're building a mental picture of this 52-year-old man, noting the specific pre-test profile: B symptoms, high inflammation, a surprisingly normal first-line workup, all situated within the context of an Indian outpatient setting. And the treating physician submitted this incredibly sharp, specific question, which is exactly what you need to generate a highly useful memo. The doctor didn't just throw their hands up and ask, "Hey, what's wrong with my patient?" They asked a highly calibrated clinical question. Which differential should I work up first? Occult malignancy, occult infection, or autoimmune? And which next line tests have the best yield before I refer? As the CRA will tell you, sharp questions get useful memos. Vague questions just don't. So within just 2 hours, the AI evidence desk generates a structured Tier 1 brief. But notice how the human CRA steps in and immediately filters out the noise. The AI pulls from heavy hitters like PubMed, Cochrane, Embase, and the WHO, right? It surfaces 7 evidence items. 3 are obvious, 2 are fantastic new additions, but 2 of them, they have to be completely discarded. Why? Because the methodology is flawed, or the population doesn't match at all. You can't just extrapolate data from a U.S. registry of geriatric inpatients for a middle-aged man in India. The AI brief is just a foundation. It is absolutely not an interpretation. From there, the CRA doesn't just stop at the AI brief. They start running highly specific clinician-level searches that a standard algorithm simply wouldn't even know how to frame.
They're digging into the diagnostic yield of tuberculosis specifically in India and checking the performance characteristics of the CBNAT molecular test on extrapulmonary samples. These aren't your standard surface-level Google Scholar searches. These are the deep, nuanced questions an experienced clinician asks when they are hunting for hidden or occult disease. The next morning, 24 hours in, after letting the complex case settle overnight, the CRA begins the meticulous process of actually drafting the interpretation. And this overnight pause, it's actually a vital part of the cognitive process. It allows the clinical picture and all that gathered evidence to really integrate in the researcher's mind. It ensures that the drafted memo isn't just some rushed, copy-pasted summary of medical papers, but a thoughtful, cohesive clinical narrative. Moving to the actual deduction, the differentials were ranked strictly on what the evidence supported, nothing else. Number 1 on the list, disseminated tuberculosis, or occult TB. Second is lymphoma, because those B symptoms are classic, which prompts a solid recommendation to check LDH and do a contrast CT. Third is autoimmune, specifically large vessel vasculitis, noting that ANA and ANCA tests would be supplementary here. They even kept infective endocarditis lower on the list just to be entirely safe and thorough. And this prioritization, it is an absolute masterclass in medical detective work, prioritizing TB over lymphoma because the specific local demographic data completely trumped a normal X-ray. Think about it. In a 52-year-old Indian man with these specific symptoms and inflammatory markers, the published yield framework heavily favors occult TB. Sure, a normal chest X-ray can be incredibly misleading in these cases, but the statistical pretest probability is very, very real. This is exactly where deep, localized evidence synthesis outsmarts basic algorithms. I absolutely love this phrase, considerations, never directives. It perfectly captures how the memo is written. It tells the doctor what the evidence supports, not telling them what to do. The CRA purposely uses phrasing like, the evidence supports considering, or a reasonable next step would be. They never cross that line into telling the treating physician how to practice medicine. In fact, if a draft even reads as slightly directive, it gets sent right back for a rewrite. Fast forward to the 42-hour mark. A senior clinical reviewer appraises the draft, adding crucial nuances, like IGRA limitations, before applying their signature. This is the 2 pair of eyes rule. Every single memo that leaves Consilium is reviewed by a senior clinician, 2 pairs of eyes every single time. In this specific case, the senior reviewer actually requested an addition regarding the limitations of the IGRA blood test, which is often used to detect TB infection in HIV-negative immunocompetent adults. It was a really sharp, vital catch that made the final memo significantly stronger. So by Thursday morning, the family physician receives this comprehensive 5-page deliverable right in his inbox, before his clinic even opens for the day. It really is a masterpiece of clinical support. The differentials are ranked, the next line tests are clearly prioritized, and, this is key, the clinical uncertainties are named out loud. It bears the signatures of both the CRA and the senior reviewer, and incredibly, it includes a fully reproducible hashed source pack, meaning the original evidence base is perfectly archived if the doctor ever needs to revisit it. And the outcome is what makes all of this worth it. The prioritized workup led straight to a contrast CT and node biopsy, officially confirming tuberculosis. The treating physician read the memo and ordered the suggested workup that very same morning. The contrast CT of the abdomen revealed mesenteric lymphadenopathy, so they did a node biopsy, ran the cBNNA test exactly as suggested by the deep evidence search, and boom, there it was, Mycobacterium tuberculosis. The occult disease was finally found. Honestly, the most rewarding part of this entire explainer is seeing the patient's recovery. 6 weeks into therapy, the patient's inflammation plummeted, and he started regaining weight. They started him on anti-tubercular therapy just 10 days after the initial Consilium submission. By week 6, that terrifyingly high ESR had been cut in half, and he had put 2 of those lost kilos right back on. This isn't just abstract research. This is real, tangible patient impact, driven by precise, evidence-based medicine. Let's just step back and look at the sheer efficiency of this entire journey. It took exactly 46 hours from submission to delivery. In less than 2 days, a complex, confusing clinical picture was transformed into a targeted, actionable, peer-reviewed medical strategy, perfectly sequenced for the treating physician. But here is the number that really matters to that busy family physician. It took him only 18 minutes to read and digest the final memo. He didn't have to spend his precious evenings endlessly scrolling through PubMed, trying to decipher study methodologies, or throwing out irrelevant papers. The Chamber Junior did all that heavy lifting for him, synthesizing it into a structured format he could consume in less than 20 minutes before his very first patient of the day even walked in the door.
And because of those 18 minutes, the treating physician estimated he saved between 4 to 6 solid hours of grueling primary medical research. That is, 4 to 6 hours of deeply focused, cognitively draining work handed right back to the doctor. You see, most cases that come through a service like Consilium aren't overly dramatic TV show mysteries. They are simply complex cases that a thoughtful physician would eventually work up correctly anyway, if they had enough time. The real magic here is giving them that time back. So, as we wrap up this explainer, I want to leave you with this question. What happens to healthcare when we finally give doctors their time back? When we leverage this Chamber Junior model to handle the heavy evidence appraisal, we absolutely aren't replacing the doctor. We're empowering them. We are letting them focus on what they do best, applying their human judgment, treating the patient sitting right in front of them, and changing lives. It really makes you wonder, doesn't it? How much faster and how much better could medicine move if every single doctor had this kind of support in their corner?